Hello, and welcome back to another stream of Advanced Pharmacology. Today we're talking about Chapter 23, Drugs for Headaches. So, drugs for headaches. Headaches is a common symptom that can be triggered by a variety of stimuli, including stress, fatigue, acute illness, and sensitivity to alcohol. Many people experience mild episodic headaches that can be relieved with over-the-counter medications, including aspirin, Tylenol, ibuprofen. For these individuals, medical intervention is unnecessary. In contrast, some people experience severe, recurrent, debilitating headaches that are frequently unresponsive to aspirin-like drugs. For these individuals, medical attention is merited. In this chapter, we focus on severe forms of headaches, specifically migraines, clusters, and tension-type headaches. When attempting to treat a headache, we must differentiate between headaches that have an identifiable underlying cause, such as severe hypertension, hyperthyroidisms, tumors, infections, any types of disorders of the eyes, ears, nose, sinuses, and throat, and headaches that have no identifiable cause, such as your migraines and again your cluster headaches. If there is a clear cause, it should be treated directly. So, the diagnosis and treatment of a headache. The following table here is an excellent spot, as always, to hit pause early on so you can review the different types of treatment options for different types of headaches. As we consider drugs for headaches, keep three basic principles in mind. First, an anti-headache drug may be used in one or two ways. The first being to abort an ongoing attack or to prevent an attack from occurring. Second, not all patients with a particular type of headache responds to the same medication. Therefore, therapy may be individualized. Third, several of the drugs employed to treat severe headaches can cause physical dependence. So, accordingly, every effort should be made to keep dependence from developing. If dependence does develop, a withdrawal procedure is necessary. So, let's start off with some migraine headaches, the characteristics, pathophysiology, and overview of treatment. Its characteristics. Migraine headaches are characterized by a throbbing head pain of moderate to severe intensity that may be unilateral or bilateral. Most patients also experience nausea and vomiting, along with neck pain and sensitivity to light and sound. Physical activity intensifies the pain. During a prolonged attack, patients may develop hyperalgesia, which is an augmented response to painful stimuli, and allodynia, painful responses to normally innocuous stimuli. Migraines usually develop in the morning after arising, and pain starts to increase gradually and lasts between 4 to 72 hours. A median attack is normally 24 hours. On average, attacks occur 1.5 times a month. Precipitating factors may include anxiety, fatigue, stress, menstruation, alcohol, weather changes, and tyramine-containing foods. Migraines have two primary forms, a migraine with an aura and a migraine without an aura. In a migraine with an aura, the headache is preceded by visual symptoms, flashes of light, a blank area in the field of vision, and possibly a zigzag pattern. Of the two forms, a migraine without an aura is more common, affecting about 70% of individuals. Migraines afflict 36 million people in the United States and more than 10% of the population worldwide. The headaches are more common and more severe in females, with a lifetime incidence of 43% compared with 18% in males. About 65% of people with a migraine are women in either their late teens, 20s, and or 30s. With some women, migraine attacks are worse during the menstruation, but subside during pregnancy and cease after menopause, indicating a hormonal component to the attack. A family history of the disease is usually typical. Migraines are usually highly debilitating An attack can prevent participation in social and leisure activities and can result in a lost productivity at home, school, and work. According to the World Health Organization, disability caused by a severe migraine attack equals that caused by quadriplegia, psychosis, or even dementia. So it's pathophysiology. Migraine headache is a neurovascular disorder that involves the dilation and inflammation of intracranial blood vessels. Headache generation, but headache generation begins with neural events that trigger vasodilation. This vasodilation then leads to pain, which leads to further neural activation, thereby amplifying pain-generating signals. Neurons of the trigeminal vascular system, which innervate intracranial blood vessels, are key components. The exact cause of migraine pain is not completely understood, although the vasodilation and inflammation are clearly involved. Available data suggests that there's two compounds, a calcitonin gene-related peptide and serotonin, as well as the hydroxytryptamine, which play important roles. The role of the CGRP is to promote migraine, and the role of a 5-HT is to suppress migraine. Data that implicates CGRP as a cause of migraine include the following. A plasma level of CGRP rise during a migraine attack. The stimulation of neurons of the trigeminal vascular system promotes the release of CGRP, which in turn promotes the vasodilation and the release of inflammatory neuropeptides. Dosing with sumatriptan, a drug that relieves migraines, lowers elevated levels of CGRP. Sumatriptan can suppress release of CGRP from cultured trigeminal neurons, data that supports a protective role in a 5-HT, including the following. Plasma levels of 5-HT drop by 50% during a migraine attack. Depletion of 5-HT with reserpine can precipitate an attack in migraine-prone individuals. And finally, the administration of a 5-HT or sumatriptan, both of which activate the 5-HT receptors, can abort an ongoing attack. So, the overview of treatment. Drugs for migraines are employed in two ways, to abort an ongoing attack and to prevent attacks from occurring. Drugs used to abort an attack fall into two groups, nonspecific analgesics and migraine-specific drugs. Drugs employed for prophylaxis include beta blockers, tricyclic antidepressants, and antiepileptic drugs. Non-drug measures can help. Patients should try to control or eliminate triggers and should maintain a regular pattern of eating, sleeping, and exercise, because in people with migraine, the brain seems to have a low tolerance for the ups and downs of life. When an attack has begun, the migraineur should retire to a dark, quiet room. Placing an eye pack on the neck and scalp may help. So, aborting therapy. The objective of abortive therapy is to eliminate the headache, pain, and suppress associating nausea and vomiting. Treatment should commence at the earliest sign of an attack, because migraines cause gastrointestinal disturbances, nausea, vomiting, and gastric stasis. Oral therapy may be ineffective after an attack has already begun. Therefore, for treatment of an established attack, a drug that can be administered by injection, nasal spray, or rectal suppository may be best. As noted, two types of drugs are used, your nonspecific analgesics and a migraine-specific agent. Representative drugs are on the following table here. An excellent spot to hit pause. Drug selection depends on the intensity of the attack. For mild to moderate symptoms, an aspirin-like drug, such as aspirin or naproxen, may be sufficient. For moderate to severe symptoms, patients should take a migraine-specific drug, such as a serotonin agonist, or less frequently used, an ergot alkaloid, such as ergotamine and a dihydroergotamine. If these agents fail to relieve the pain, an opioid analgesics, such as butorphanol, may be needed. Note that opioids should be reserved for treatment in patients with migraines resistant to all other treatments. So, opioids are not the drug of choice. Use of abortive medications, both non-specific and migraine-specific, should be limited to 1 or 2 days a week. More frequent can lead to a medication overuse headache, also known as a drug-induced headache or drug rebound headache. Antiemetics are important adjuncts to migraine therapy. By reducing nausea and vomiting, these drugs can make the patient feel more comfortable and permit therapy with oral anti-migraine drugs. Two antiemetics, metoclopramide, Reglan, and prochlorperazine, also known as compazine, are used most often. Of the two, Reglan is preferred. In addition to suppressing nausea and vomiting, Reglan can reverse gastric stasis caused by the attack and can therefore facilitate absorption of oral anti-migraine drugs. Like Reglan, compazine suppresses nausea and vomiting. However, because of its anticholinergic action, compazine can make the gastric stasis even worse. So, analgesics, your aspirin-like drugs. Aspirin, Tylenol, naproxen, diclofenac, and other aspirin-like analgesics all can provide adequate relief to a mild to moderate migraine headache. In fact, when combined with Reglan, aspirin may work as well as sumatriptan, a highly effective anti-migraine drug. Moreover, the combination of aspirin plus Reglan costs less than sumatriptan and causes fewer side effects. Tylenol should be used only in combination with other drugs, not one alone. One effective combination, marketed as Excedrin migraine, consists of Tylenol, aspirin, and caffeine. Your opioid analgesics. Again, not the primary drug of choice, but opioid analgesics are reserved for severe migraines that have not responded to first-line medication. This is because of the potential for abuse as well as a withdrawal headache when the medication is stopped. So the only one opioid analgesics that is recommended is butyrophonal nasal spray. Your serotonin receptor agonists, your triptans. So serotonin receptor agonists, also known as triptans, are the first-line drugs for terminating a migraine attack. These agents relieve pain by constricting intracranial blood vessels and suppressing the release of inflammatory neuropeptides. All are well tolerated. Rarely, they cause symptomatic coronary vasospasms, and the following table here presents the clinical pharmacology of the triptans. An outstanding section to hit pause so you can look at all of them. And I'll leave that up for just a moment. So, speaking on sumatriptan. Sumatriptan, also known as Imitrex, was the first triptan available and will serve as the prototype for this group. The drug can be administered by mouth, nasal inhalation, or subcutaneous injection. Additionally, an iontophoretic transdermal system has been approved in 2013. So how does it work? Its mechanism of action. Sumatriptan, an analog of the 5-HT, causes the selective activation of 5-HT and 5-HT receptors. The drug has no affinity for 5-HT2 or 5-HT3 receptors, nor does it bind to adrenergic, dopaminergic, muscarinic, or histaminergic receptors. Binding to 5-HT, the 1B1D receptors on the intracranial blood vessels, causes vasoconstriction. Binding to 5-HT, 1B1D receptors on sensory nerves of the trigeminal vascular system suppresses the release of the CGRT, a compound that promotes the release of inflammatory neuropeptides. As a result, sumatriptan reduces the release of inflammatory neuropeptides and therefore diminishes perivascular inflammation. Both actions, vasoconstriction and a decreased perivascular inflammation, help relieve migraine pain. Its therapeutic use. Sumatriptan is taken to abort an ongoing migraine attack. The drug relieves headaches and associated symptoms, nausea, neck pain, photophobia, and phonophobia. In clinical trials, sumatriptan gave complete relief to most patients. Beneficial effects began about 15 minutes and after a subcutaneous or intranasal dosing, and 30 to 60 minutes after an oral dose. Complete relief occurred in 40% to 60% of patients in 2 hours after a sub-Q dose, and in about 30 to 60% of patients after 2 hours after an intranasal dose. Only 18% of patients after a 2 hour after a transdermal dose, and 50 to 60% of patients 4 hours after an oral dose. Unfortunately, headache returns in about 40% of patients within 24 hours. In comparison, the 24-hour recurrence rate with a dihydroergotamine is only 14%. In patients who respond to a subcutaneous sumatriptan, subsequent administration of oral sumatriptan can delay recurrence, but does not prevent it. In addition to migraine, sumatriptan is approved also for cluster headaches. So, its pharmacokinetics. With oral or intranasal dosing, the bioavailability is actually relatively low, only about 15%. The transdermal system is even lower, which only has about a 6%, whereas the sub-Q dosing bioavailability is extremely high at 97%. As a result, oral and intranasal doses are considerably higher than sub-Q and transdermal doses. Sumatriptan undergoes an extensive hepatic metabolism, primarily by a monoamine oxidase, followed by the excretion in the urine. A half-life is short, about 2.5 hours. So, sumatriptan has side effects, which are generally well tolerated, but the most side effects are transient and mild. Your coronary vasospasm is the biggest concern. So, chest symptoms. About 50% of patients experience unpleasant chest symptoms, usually described as heavy arms and chest pressure rather than pain. These symptoms are transient and not related to any kind of ischemic heart disease. Possible causes are pulmonary vasoconstriction, esophageal spasms, intercostal muscle spasms, and bronchoconstriction. Patients should be forewarned of these symptoms and be reassured that they are not dangerous. Your coronary vasospasm. Very rarely, sumatriptan and other triptans can cause angina, secondary to a coronary vasospasm. Your EKG changes have been observed in patients with coronary artery disease or Prinzmetal angina. To reduce the risk for angina, avoid sumatriptans in patients with risk factors for CAD until CAD already has been ruled out. These patients include your postmenopausal women, men older than 40, your smokers, and patients with hypertension, hypercholesteremia, diabetes, or a family history of CAD. Owing to the risk for coronary vasospasm, sumatriptan is contraindicated for patients who have a history of ischemic heart disease, myocardial infarctions, or uncontrolled hypertension, or any other types of heart disease. Teratogenesis. Sumatriptan should be avoided during pregnancy. When given daily to pregnant rabbits, the drug was embryo-lethal at blood levels at only 3 times higher than those achieved with a 6 mg sub-Q injection in humans, which is the typical dose. So, unless the prescriber directs otherwise, women should not be given this medication if they are pregnant or if we think they might be. If they are trying to become pregnant, or if they are not using adequate forms of contraception, again, the medication should not be used. And the FDA classifies this medication as a risk category C. Other adverse effects. Mild reactions may also include vertigo, malaise, fatigue, and a tingling sensation. Your transient pain and redness may occur at sites of subcu injection. The intranasal formulation tastes bad and may irritate the nose and throat. Other drug interactions, ergoalkaloids and other triptans. Your sumatriptan and other triptans, such as your ergoalkaloids, all cause vasoconstriction. Accordingly, if one triptan is combined with another or with an ergoalkaloid, excessive and prolonged vasospasm may result. Therefore, your sumatriptan should not be used within 24 hours of an ergo derivative or another triptan. Your monoamine oxidase inhibitors, also known as your MAOIs, can suppress hepatic degradation of sumatriptan, causing its plasma level to rise. Toxicity can result. Accordingly, sumatriptan should not be combined with a MAOI and should not be used within 2 weeks of stopping a MAOI. Your SSRIs, or selective serotonin reuptake inhibitors, and your serotonin norepinephrine reuptake inhibitors, your SNRIs, are discussed in Chapter 25. The SSRIs and SNRIs indirectly activate serotonin receptors in the brain. If receptor activation is excessive, your serotonin syndrome can occur. Your signs and symptoms include altered mental status, agitation, confusion, disorientation, anxiety, hallucinations, and poor concentration, as well as incoordination, myoclonus, hyperreflexia, excessive sweating, tremors, and fevers. Deaths have occurred. Because the triptans directly activate your serotonin receptors, and the SSRIs and SNRIs indirectly activate serotonin receptors, you can see how combining these drugs can lead to excessive receptor activation. Accordingly, these combinations should never be used. Your salmetriptan is indicated for terminating an ongoing migraine attack. The drug is similar to sumatriptan with regard to its mechanism, efficacy, time course, side effects, and interactions. However, it is formulated for oral and intranasal use. Effects from intranasal administration begin in 15 minutes compared to the 45 for the oral products. However, although the nasal spray is faster, it has two major drawbacks. It tastes bad and only has one strength, which is available. If a smaller dose, for instance, is needed, an oral formulation must be utilized. Regardless of the formulation, about 65% of patients usually respond within 2 hours. If the headache persists, dosing can be repeated 2 hours after the initial dose. The maximum dose per 24 hours is 10 milligrams. Headaches recurs in 8% to 32% of patients. Adverse effects are generally mild and transient. So, similar to sumatriptan, silmatriptan causes harmless transient chest discomfort. Of much greater concern, though, the drug can cause coronary vasospasm and therefore is again contraindicated with patients who have ischemic heart disease, prior MIs, or uncontrolled hypertension. So again, similar to sumatriptan, sulmatriptan should not be administered within 24 hours of an ergo alkaloid or another triptan or within 2 weeks of stopping a MAOI. To avoid that serotonin syndrome, sulmatriptan should not be combined with an SSRI or SNRI. Bringing us to naratriptan. Naratriptan, or Amarge, is indicated for oral therapy of an ongoing migraine attack. Compared with other triptans, naratriptan has a slower onset, but a longer duration. Because its effects persist, the 24-hour migraine reoccurrence rate is slightly reduced. Like other triptans, naratriptans can cause a transient chest discomfort, and like other triptans, the drug can cause coronary vasospasms, and therefore is contraindicated with patients with ischemic heart disease, past MIs, and uncontrolled hypertension. To avoid that excessive vasospasm, neurotriptan should not be administered within 24 hours of an ergo alkaloid or another triptan. And again, like the other triptans, do not use it with SSRIs or SNRIs owing to the risk for the serotonin syndrome. However, in contrast to some of the other triptans, neurotriptan is safe to use with a MAUI. Rizatriptan. Rizatriptan, also known as Max-Alt, may be the most consistently effective triptan for terminating an ongoing migraine attack. The drug is similar to a sumatriptan with regard to the mechanisms, efficacy, time course, side effects, and interactions. Adverse effects are generally mild and transient, and similar to other triptans, rizatriptan causes harmless transient chest discomfort. Also, like other triptans, the drug can cause coronary vasospasms. So again, don't use it if you have a ischemic heart disease, prior MIs, or uncontrolled blood pressures. To avoid excessive vasospasms, rizatriptan should not be administered within 24 hours of an ergo alkaloid or other triptan, or within 2 weeks of stopping a MAUI. So, like the other triptans, rizatriptan should not be combined with SSRIs or SNRIs, as it also causes a risk for serotonin syndrome. Medications including propranolol can raise levels of rizatriptan, so there may be a requirement to reduce a rizatriptan dosage if they are also on propranolol. Rizatriptan may also cause harm to the developing fetus. So, in drug trials in rats, the drug increased perinatal mortality, reduced learning capacity, and decreased the pre-weaning and post-weaning weight. However, post-marketing studies suggested that in humans, rizatriptan may not increase the risk for congenital abnormalities or spontaneous abortions. Because these studies were done on such a small population, the drug should be used with extreme caution in patients who are pregnant or who are trying to become pregnant. And further research is definitely still needed, as it is currently considered incomplete. Your almotriptan or Axert is indicated for oral therapy of an ongoing migraine attack. These drugs are similar to the sumatriptan with regard to, again, the mechanism of action, efficacy, and time course, and it is better tolerated. Adverse effects are generally minimal, and like other triptans, amitriptan can cause harmless transient chest discomfort, but the incidence is extremely low. Also, like other triptans, the drug can cause coronary vasospasms. So, like all the others, don't use it if you have a history of ischemic heart disease, past MIs, or uncontrolled hypertension. Amitriptan, however, is metabolized by CYP3A4, which is part of that P450 cytochrome isoenzyme family. And therefore, the dosage reduction is recommended if the drug is combined with other potent CYP3A4 inhibitors. To avoid excessive vasospasms, amitriptan should not be administered within 24 hours of the ergo alkaloid or other triptans. Like other triptans, amitriptan should not be combined with SSRIs or SNRIs, again owing to the risk for the serotonin syndrome. However, in contrast to some of the other triptans, it is safe to use if you are on a MAUI. Frovatriptan or Frova is indicated for oral therapy of an ongoing migraine attack. The drug is similar to the other triptans in regard to the mechanism of action, side effects, but is less effective and has very different kinetics. Effects begin slowly and are sustained thanks to the drug's long half-life of 26 hours. Although the number of patients responding at 2 hours is very low, rates of headache recurrence are also very low, lower than any other triptan. Adverse effects are mild and transient. Like sumatriptan, frovatriptan can cause, again, the harmless transient chest discomfort. In addition, the drug can cause coronary vasospasms, so again, if you have ischemic heart disease, past MIs, or uncontrolled hypertension, don't use the medicine. Again, to avoid excessive vasospasms, don't take these with any other ergoalkaloids or other triptans. However, the pros, it can be used with a MAUI. So like other triptans, frovatriptan should not be combined with SSRIs or SNRIs, but MAUIs, again, are okay. Elatriptan, or Relpax, is indicated again for oral therapy of the ongoing migraine attack. This drug, however, is at least as effective as oral sumatriptan and may have a faster onset. Like the other triptans, Elatriptan can cause transient chest discomfort. Also, like the other triptans, it can cause coronary vasospasms. So again, it's contraindicated in your ischemic heart disease patients, past MI patients, or those with uncontrolled hypertension. To avoid excessive vasospasms, elatriptans should not be administered within 24 hours of an ergoalkaloid. However, the drug is okay to be used with someone who's taking a MAUI. Because elatriptan is not broken down by MAOs, elatriptan is metabolized in the liver by the CYP3A4, that isoenzyme. And thus, a strong inhibitor of CYP3A4 may need to have a lower dose to prevent toxicity. Accordingly, elatriptan should not be used within 72 hours of any of those medications who do utilize CYP3A4 metabolism. A moderate CYP3A4 inhibitor used for migraine prophylaxis is advised to be used with caution. Like other triptans, elatriptan should not be combined with SSRIs and SNRIs. Again, the risk for serotonin syndrome is high. So here we have some prototype drugs for migraines, nonsteroidal anti-inflammatory drugs, your SSRAs, and ergoalkaloids. So speaking on that ergoalkaloid, ergotamine, the mechanism of action of an anti-migraine action. Ergotamine has a complex action, and the precise mechanism by which it aborts a migraine is technically unknown. Ergotamine can alter the transmission of your serotonergic, dopaminergic, and alpha-adrenergic junctions. Currently, evidence suggests that anti-migraine effects are related to the agonist activity at subtypes of serotonin receptors, specifically that 5-HT1B and the 5-HT1D receptors. Additional evidence indicates that ergotamine can block inflammation associated with the trigeminal vascular system, perhaps by suppressing the release of that CGRP. Relief may also be related to vascular effects. In cranial arteries, ergotamine acts directly to promote constriction and reduce the amplitude of pulsation. In addition, the drug can affect blood flow by depressing the vasomotor center. So, its therapeutic use. Ergotamine is used as a second-line drug, used for stopping an ongoing migraine attack in patients who have not responded to a triptan. Owing to the risk for dependence, however, ergotamine should not be taken daily or on a long-term basis. Its pharmacokinetics. Administration may be oral, sublingual, or rectal. The bioavailability with oral and sublingual administration is low. Its bioavailability with a rectal administration, however, is much higher. Although the half-life is only about 2 hours, the pharmacologic effects can still be observed 24 hours after dosing. Ergotamine undergoes the metabolism of that CYP3A4, followed by the excretion in bile. So, what are some adverse effects? Ergotamine is well tolerated, as usual, at usual therapeutic doses. The drug can stimulate a chemoreceptor trigger zone, however, which would cause you nausea and vomiting in about 10% of your patient population. Therefore, augmenting nausea and vomiting caused by the migraine itself. Concurrent treatment with Reglan or Compazine, those antiemetics, can help reduce these responses. The other common side effects include weakness in the legs, myalgia, numbness and tingling in the fingers and toes, angina-like pain, and tachycardia, or the opposite, bradycardia. Overdose. Acute or chronic overdose can have serious toxicity, referring to ergotism. In addition to these adverse effects seen in therapeutic doses, overdoses can cause ischemia, secondary to the constriction of the peripheral arteries and arterioles. The extremities start to become cold, pale, and numb. Muscle pain develops, and gangrene can actually occur. Patients should be informed about these responses and be instructed to seek immediate medical attention if they develop. The risk for ergotism is highest in patients who suffer from sepsis, peripheral vascular disease, and renal or hepatic impairments. Management consists of discontinuing the medication entirely, followed by measures to maintain the circulation, the treatment with an anticoagulant and IV nitroprusside, phentolamine, or nitroglycerin as appropriate. So it's drug interactions. Again, so we talked about it a little bit with the triptans when we talked about triptans, but speaking on triptans now on the ergotamine side, they should not be combined with triptans because of the prolonged vasospastic reaction that could occur. To avoid this problem, dosing with ergotamine and serotonin agonists should be separated by at least 24 hours. The physical dependence. Regular daily use of ergotamine, even in a moderate dose, can cause a physical dependence. The withdrawal syndrome is characterized by headache, nausea, vomiting, and restlessness. That is, the withdrawal resembles a migraine attack. Patients who experience these symptoms are likely to resume taking the drug, therefore perpetuating the cycle of dependence. Hospitalizations may be required to break the cycle. To avoid dependence, dosage and duration of treatment must be restricted. So you might need to take a look at a closer dosing guideline later on in this section. Its contraindications. Again, ergotamine is contraindicated with patients who have a history of hepatic or renal impairment, people who suffer from sepsis because of the possible gangrene that may result, your coronary artery disease, your peripheral vascular disease, and uncontrolled hypertension for those who are taking a potent CYP3A4. In addition, the drug should not be taken during pregnancy because it can promote that uterine contractions and therefore can cause potential harm to the fetus or even trigger an abortion. In fact, because of its effects on the uterus, ergotamine is classified in the FDA pregnancy risk as Category X. The risk of use by pregnant patients clearly outweighs any possible benefit. Warn women of childbearing age to avoid pregnancy when they are taking this medicine. Your dihydroergotamine. So, it's therapeutic use. Parenterally, your dihydroergotamine, or DHE45, also known as migranal, given by the intramuscular IM, IV, or subcutaneous route, again is a second-line drug for terminating a migraine attack. The drug also may be given by an intranasal spray. A formulation for oral inhalation is undergoing review by the FDA. Your intranasal dihydroergotamine is less effective than an intranasal sumatriptan, but is associated with a lower rate of migraine recurrence. So, the pharmacologic effect. The actions of the dihydroergotamine are similar to those of ergotamine. Like ergotamine, your dihydroergotamine alters the transmission of serotonergic, dopaminergic, and alpha adrenergic junctions. However, in contrast to ergotamine, the dihydroergotamine causes little nausea or vomiting, so no physical dependence and minimal peripheral vasoconstriction occurs when used alone. However, there is the side effect of diarrhea, which is extremely prominent. So it's pharmacokinetics. This medication is administered parenterally or by nasal spray, but not by mouth, owing to the extensive first-pass metabolism. In the liver, the drug is metabolized again by CYP3A4, an active metabolite. The 8-hydroxydihydroergotamine contributes to the therapeutic effects. The half-life of the medication plus the active metabolite is about 21 hours, which brings us to a black box warning on ergotamine and the dihydroergotamine. Potent inhibitors of CYP3A4 can raise ergotamine to dangerous levels, posing a risk for intense vasospasm. Cerebral and/or peripheral ischemia can occur. Accordingly, concurrent use with other CYP3A4 inhibitors is strictly contraindicated. So other abortive agents, your sumatriptan and naproxen. Sumatriptan and naproxen, a nonsteroidal anti-inflammatory drug, are available in fixed-dose combination under the trade name Treximet. In clinical trials, the combo drug was better than either agent alone at relieving the pain of a migraine attack. In addition, the combination effectively reduced nausea and sensitivity to both light and sound. Presumably, the superior benefit of the combination derive from attacking migraine by multiple mechanisms. Your naproxen reduces pain and inflammation, while your sumatriptan causes the vasoconstriction and the inhibition release of inflammatory neuropeptides. Which brings us, however, to a black box warning on Treximet, or that combination drug. Treximet increases the risk for serious GI bleeding and other potentially fatal adverse effects, including stomach and/or intestinal perforation. So, it's preventative therapy. In 2012, the American Academy of Neurology and the American Headache Society published a new guideline on the pharmacologic treatment for the prevention of migraines. The evidence-based guideline update the pharmacologic treatment for episodic migraine prevention in an adult. Prophylactic therapy can reduce the frequency, intensity, and the duration of migraine attacks, and can improve the responses to abortive drugs. Preventative treatment is indicated for patients who have frequent attacks, about 3 or more a month, attacks that are especially severe, or attacks that do not respond to adequate or abortive agents. Preferred drugs for the prophylaxis include propranolol, divalproex, and amitriptyline. All three are effective and well tolerated, and with all three benefits take between 4 to 6 weeks to develop. Major preventative agents are listed here in the following table, which is an excellent spot to hit pause so you can take a look at all the different migraine headaches, the drugs for preventative therapy. So, beta blockers. Beta blockers are the first-line drug for migraine prevention. Of the available beta blockers, propranolol is used most often, although metoprolol is now deemed as effective as propranolol. Treatment can reduce the number and the intensity of attacks in about 70% of patients. The benefits take a few weeks to develop. The most common side effects are extreme tiredness and fatigue, which occurs in about 10% of patients. In addition, the drug can exacerbate symptoms of asthma and might promote depression. If the patient is on rizatriptan, which is used for abortive therapy, its dosage must be reduced. In addition to propranolol and metoprolol, three other beta blockers, utimolol, atenolol, and nadolol, can help prevent migraine attacks. In contrast, beta blockers that possess intrinsic sympathomimetic activities, isobutalol and pindolol, are not effective. The basic pharmacology of beta blockers will be discussed further in Chapter 14. Your anti-epileptic drugs. Several drugs that were developed for epilepsy can reduce migraine attacks. Proof of efficacy is strongest for a medication by the name of Depakote or topiramate. Gabapentin and tiagabine appear promising, although extensive proof is currently lacking in its efficacy. So we'll start off with Depakote. Depakote, employed first for epilepsy and later for bipolar disorder, is now approved also for the prophylaxis of migraines. The drug is a form of valproic acid. Depakote reduces the incidence of attacks by 50% or more in 30 to 50% of patients. However, when attacks do occur, their intensity and duration are not diminished. In patients with migraines, the most common side effect is nausea. The other side effect is fatigue, weight gain, tremors, bone loss, and the reversible hair loss. So, the black box warning of Depakote. Potentially fatal pancreatitis and hepatitis have occurred. In addition, Depakote can cause neural tube defects in a developing fetus and therefore is contraindicated and is a category X in patients who are pregnant. Topiramate or Topamax, originally developed for epilepsy, was again approved for migraine prophylaxis back in 2004. The benefits take several weeks to develop and appear equal to those of beta blockers, tricyclic antidepressants, or Depakote. However, topiramate costs much more than these drugs, and in clinical trials, Topamax reduced migraine frequency by at least 50 to 83% of adolescents and about 50% of adults. The drug also reduced the need for rescue medication. However, side effects are common, especially paresthesias, fatigue, and unfortunately, cognitive dysfunction, psychomotor slowing, word finding difficulty, impairment of concentration and memory. Other side effects include the metabolic acidosis and moderate weight loss, owing to the anorexia, nausea, and diarrhea. So, to minimize those side effects, dosages should be low initially and then gradually be increased. Again, the basic pharmacology of Topamax is discussed in further detail in Chapter 19. The tricyclic antidepressants. Tricyclic antidepressants can prevent migraine and tension type headaches in some patients. The underlying mechanism has not been established, but may involve inhibiting the reuptake of serotonin, making more of a transmitter available for action. The tricyclic agent used most often is amitriptyline or Elavil. Because Elavil is effective in patients who are not depressed, it would seem that benefit do not depend on the elevation of mood. Like other tricyclic antidepressants, Elavil can cause hypotension and anticholinergic effects, such as your dry mouth, constipation, urinary retention, blurred vision, and tachycardia. Excessive doses also can cause dysrhythmias. The basic pharmacology of Elavil is discussed in further detail in Chapter 25. Which brings us to estrogens and triptans for the menstrually associated migraines. Menstrually associated migraines is defined as a migraine that routinely occurs within 2 days of the onset of menses. An important trigger is the decline of estrogen levels that precedes menstruation. For many women, menstrually associated migraines can be prevented by taking estrogen supplements. Just lost my spot. There it goes. Which may compensate for the premenstrual estrogen drop. Topical preparations, estrogen gel, and estrogen patches work well. Your perimenstrual triptans can also help. For example, your frovatriptan, niratriptan, and solmatriptan can reduce the frequency, intensity, and duration of menstrually associated migraines. Dosing is done for 6 days each month, beginning 2 days before the expected onset of menses. In addition, naproxen sodium at a dosage of 550 milligrams twice daily, given 6 days before to 7 days after menses, has demonstrated effectiveness in the prevention of a migraine. Which brings us to other drugs for prophylaxis. Your botulinum toxin. In 2010, the FDA approved injection of botulinum toxin, also known as Botox, for the prevention of headaches in adults with a chronic migraine, defined as having 15 or more headaches or headache days per month, but not for patients with less frequent headaches. Treatment consists of 31 injections made into the muscles of the scalp, neck, and upper back. Treatment is expensive and the benefits are modest on average. Patients experience about 2 fewer headaches days per month. So, I don't know if that's truly worth it. Your black box warning, botulinum toxin. Again, your Botox can spread from the site of injection and produce muscle weakness, difficulty with respirations, and swallowing difficulties that can be life-threatening. Which brings us to our cardiac drugs, your angiotensin converting enzyme inhibitors, your ACE inhibitors, and your angiotensin 2 receptor blockers, your ARBs. So, for the prophylaxis of migraines, ACE inhibitors and ARBs are considered the third line drugs. The benefits are limited to 25% reduction in migraine days. However, side effects include hyperkalemia, hypotension, volume depletion, and angioedema. When used during pregnancy, these drugs can injure the developing fetus. How ACIs and ARBs reduce migraine attacks is completely unknown, although it is thought that they may stabilize your blood vessels and therefore alter that sympathetic activity. The basic pharmacology of the drugs are discussed in Chapter 36 under cardiac. Other supplements, your riboflavin. Riboflavin, also known as vitamin B2, can reduce the number and severity of migraine attacks, but benefits are considered modest and develop very slowly. In one study, patients with migraines with frequent attacks who took 400 milligrams of vitamin B2 a day, after about 3 months, the number of attacks was decreased by 37%. In addition, the average duration of each attack also seemed to decline, and side effects were considered minimal. Coenzyme Q10. In two different studies, a daily therapy of the coenzyme Q10 produced a significant reduction in the occurrence of migraine attacks when compared with a placebo. Subjects who took about 150 milligrams of this coenzyme Q10 each morning or 100 milligrams 3 times daily. After about 3 months, the number of days on which the headache occurred seemed to have declined by at least 50 to 61%, and 47% of the participants, respectively. However, although the headache frequency seemed to have declined, headache intensity was not affected. So the coenzyme Q10 seemed to have been well tolerated. And last one, Butterbur. Extracts made from the root of a pedicite hybridus, which is a plant whose common name is butterbur, can reduce the frequency of migraine attacks. In a double-blind placebo-controlled trial, about 1 in 5 patients who took 75 milligrams of the extract twice daily experienced about a 50% or greater reduction in migraine frequency. The only side effects were mild GI upset, nausea, burping, and stomach pain. However, butterbur root contains a pyrrolizidine alkaloid, which, if not removed during the processing, can cause severe liver damage and cancer. In the study noted, the preparation employed, sold as Petadolex, was pyrrolizidine free. So that pretty much spoke up on all the migraine headaches. Now let's talk about the cluster headaches. So what is a cluster headache? Cluster headaches occur in a series of clusters of attacks. Each attack lasts between 15 minutes to about 2 hours and is characterized by severe throbbing, unilateral pain in the orbital temporal area. The typical cluster consists of 1 or 2 such attacks every day for about 2 to 3 months. An attack-free interval of months to years separate each cluster. Along with headaches, patients usually experience lacrimation, conjunctival redness, nasal congestion, rhinorrhea, ptosis, and meiosis, all of the same side of the headache. Although related to the migraine, cluster headaches differ in several ways. They are not preceded by an aura, they do not cause nausea or vomiting, they can be more debilitating, and they are less common and occur mostly in males. So your migraine headaches were mostly in females, cluster headaches mostly in males. They are not associated with any kind of family history of attack, and management is somewhat different. So our drug therapy, prophylaxis. Primary therapy is directed at prophylaxis. Effective agents include glucocorticoids, so prednisone and dexamethasone, verapamil, and lithium. A high dose of prednisone from 40 to 80 milligrams per day or dexamethasone 4 milligrams twice daily act rapidly, producing results in about 48 hours. However, long-term use of a glucocorticoid carries serious risk, which has been discussed in Chapter 56. Treatment should stop in 1 to 2 months. Verapamil is the first-line agent for preventing chronic cluster headaches. This drug is effective, easy to use, and is considered safe. Lithium is considered a second-line drug for prophylaxis. The drug is effective, but can cause multiple adverse effects, and dosing is considered difficult. To ensure the therapeutic effects and minimize toxicity, the blood levels of lithium must be monitored. The target range is 0.4 to 0.8 MEq per liter. With all of these drugs, the prophylactic therapy should be limited to the cluster cycle and then be discontinued when the current cycle is over. Drugs for prophylaxis are here on the following table. Now let's see if I can put it all in one section so you can pause and review them. So, treatment. If an attack occurs despite preventative therapy, it can be aborted with sumatriptan or oxygen. Again, sumatriptan 6 milligrams sub-Q is the treatment of choice for a cluster headache. Having an inhalation of 100% oxygen is also highly effective and virtually has no adverse effects. In the past, ergo preparations were commonly used. However, their use today is very limited because modern trials are small in populations and they lack evidence that these drugs work any better than the relieving cluster headaches than a placebo. Which takes us now to the last type of headache, your tension type headaches. So the characteristics. Tension type headaches are the most common headache type. These headaches are characterized by moderate, non-throbbing pain, usually located in the head band distribution. Headache is often associated with a scalp tingling and a sense of tightness or pressure in the head and the neck. Your precipitating factors include eye strain, aggravation, frustration, and life's daily stresses. Depressive symptoms, such as your sleep disturbances, include the early and frequent awakening, are often present. Tension headaches may be episodic or chronic. By definition, a chronic tension type headache occurs 15 or more days per month for at least 6 months. Its treatment. So, an acute attack of mild to moderate intensity can be relieved with a non-opioid analgesic. So, we have our Tylenols and our non-steroidal anti-inflammatory drugs. So, your aspirin, ibuprofen, and naproxen. An analgesic sedative combination, such as your aspirin, bu- butalbital, may also be used. However, because of their potential for dependence and abuse, the combinations should be reserved for acute therapy of episodic attacks, and they are inappropriate for patients who have chronic daily headaches. For prophylaxis, your amitriptyline or Elavil, a tricyclic antidepressant, is the drug of choice. Dosing at bedtime, which will help relieve any depression-related sleep disturbances, in addition to protecting against headaches. Your amitriptyline can, however, cause anticholinergic side effects, again, dry mouth, constipation, and pose a risk for cardiotoxicity in extreme high doses. So we'll discuss that more in chapter 25. In addition to receiving drugs, patients should be taught how to manage stress. Instructions should include the cognitive coping skills and information on relaxation techniques, such as massage, hot baths, biofeedback, and deep muscle relaxation. Which brings us to our last section here, medication overuse headaches, also known as MOH, is a chronic headache that develops in response to frequent use of headache medicines and that resolves days to weeks after the overused drug is withdrawn or discontinued. The stage for MOH is set when the headache drugs are taken too often, especially if the dosage is high. Discontinuing the medication brings on the MOH, which causes the patient to resume taking the medicine, setting up a repeating cycle of MOH followed by medication use and discontinuation, followed by another MOH, and so on. One reason the cycle gets established is that the patient doesn't realize that the drugs they're taking to treat the headache can, if taken too often, become the cause of the headache. Failing to recognize MOH for what it is, patients then take more and more medicine to make their headache go away, but only succeed in making the MOH worse. Almost all of the medicines used for the abortive therapy for headaches can cause MOH. So whether it's an analgesics, such as your aspirin-like drugs and opioids, your triptans, your ergotamine, but not your dihydroergotamine, and caffeine. The treatment for MOH is to stop taking all headache medications. Unfortunately, when medication is withdrawn, headaches increase for a while. The duration and intensity depend on the drug that was overused. With triptans, withdrawal headaches are relatively mild and often resolve in a few days. In contrast with analgesics or ergos, the withdrawal headache are more intense and may persist for 2 weeks or more. Several measures can decrease the risk for developing MOH. The most important is to limit the use of abortive medicines. If possible, patients should take these drugs no more than 2 to 3 times a week, and doses should be no higher than actually needed. Alternating headache medicine may help too, because this would limit exposure to one drug. If headaches begin to occur more than 2 to 3 times a month, the prophylactic therapy should be tried. Implementing a non-drug measure, stress reduction, avoiding of triggers, getting insufficient sleep, relaxation techniques, and biofeedback all can reduce the need for headache medications and therefore can decrease the drugs that can cause MOH. So that should conclude our chapter here for today. As always, I thank you all for listening, and I'll see you at the next chapter. Till then, thank you and have a good day.